Welcome everyone to today's program. I am Carrie Palladay with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Today's speaker is Tara Vale with HST Pathways. She has over 15 years of experience in the healthcare industry on both the provider and the vendor sides of the business. Tara began her career in the ASC industry, responsible for billing and collections. As the company grew, she led the efforts in selecting and implementing and converting 10 ASCs from disparate software platforms over to one enterprise information system. Since that time, she has served in a broad range of leadership roles, including revenue cycle management, financial operations, and analytics, business development, marketing, and sales. At HST Pathways, she is the Vice President of Marketing and has also been a part of the EHR development team since the beginning. It is now my pleasure to turn the floor over to Tara to begin today's presentation.
Thank you, Carrie, and thank you everyone for joining today's webinar. There is so much buzz about EHRs in the ASC today. Do I need it? When do I need it? What do I need to know? Where do I even begin? These are all really great questions and probably why a good number of you are on today's call. Hopefully I can shed some light on those questions and give you some insight into the value of EHRs for the ambulatory surgery setting. And I'll also provide you some tools and questions you can use to help with your evaluation of systems. So I've sat on many webinars myself and they tend to be pretty formal. So hopefully we can have a little fun today. Here we go. It is the year of Back to the Future. Can you believe this movie came out in 1985? Now here we are in 2015, and so much has changed. The internet, in fact, that you just logged into for this webinar didn't even exist in 1985. Healthcare is on the same parallel fast track that technology is on. It has to. Healthcare costs are rising so fast that trends need to change for all of our sake. ASCs are a part of that solution. ASCs haven't been around all that long and have been on the leading edge of things. Really, it's always been on the cutting edge of things. We are consistently safer, we're lower cost, and we're more patient-friendly than a hospital. Technology is another part of that solution. Decreasing costs cannot happen without technology or interoperability. I hear people say, I'm waiting to see what the government does in the future. Well, that future is right now. That ship has sailed. It's a matter of when, not if, as far as ASCs being required to have an EHR. So today we're going to talk about some of those common barriers to EHR adoption that you may be facing. So why should you do it now? We'll cover that as well. And what should you be looking for to future-proof and protect your investment? Key things hindering EHR adoption in ASCs, the horror stories, if you will. Either you've experienced yourself or your staff has worked in the hospital or they've worked in different settings or you've just read about it. The barriers can be split into three general categories: finances, operations, and technology. So starting with finances, there aren't any government incentives for ASCs to implement an EHR. Reimbursements continue to get lowered, and now an added cost for an EHR, it's the trifecta for a perfect storm. Some of you may be thinking, how do you know that the government won't start paying incentives for ASCs to adopt an EHR? Well, the high-tech provision of the Affordable Care Act, aka Obamacare, that passed in 2009, that's already paid out more than $30 billion to hospitals and physicians. So continuing on that path is not sustainable either. In fact, the government's already started dialing back. In March of this year, the Sustainable Growth Rate Fix, which is also known as the DOC Fix, passed and it really changed that playing field. Now incentives and penalties of 3 different programs are all rolled into one, and the EHR incentive was one of those things. So in truth, there may end up being some incentive, but it will likely be a fairly small amount if it does happen. So this next category is probably the one that is most blogged about, written about, and vocalized as far as EHRs. The article will typically read something like this. My charting takes longer, and because it takes longer, there's less time to see patients, and my volumes are now declined, and it takes more people to do the same job. As a result of those things, we take a direct hit to the bottom line. Well, who in any healthcare segment can afford to do that? Moving over to workflow, the workflow doesn't match the patient flow. So you hear people having to create workarounds, or they're still using paper to some degree. To overcome that, communication between clinicians is not real time, and that causes patient care risks, or poor customer support. Now this is one that's bothersome to me, because when it comes to user adoption, I can't think of anything worse than having clinicians who are converting from paper to digital world and not able to get timely support when they need it, especially when technology tends not to be the clinician's comfort zone. The last one is limited or poor connectivity. This goes to the heart of no interoperability. You may already have a few types of clinical systems in your centers, but if the systems don't talk to each other, your staff may be doing manual data entry to get that data from one system to another, which leads into the third category. There truly are no consistent data standards. Interoperability is a huge problem in healthcare because of this lack of consistency, and Meaningful Use Stage 3 really tries to address that in a big way. So there are some standards, HL7 is one of them, but even with HL7, not all vendors can send and receive the same amount of data in the same type of HL7 message. One vendor may be able to send 20 pieces of information about a patient, and the other vendor can only accept 5 of those things. That leaves you as a user at the center still not able to achieve the interoperability and automation that you're looking for. You're still stuck. For the third one, remember that commercial where the guy says, I'm a Mac, and the other guy goes, I'm a PC. These are 2 totally different operating systems, and quite often assist software can work on only one of them. What if it's not the one your user wants? Or, more likely than not, what if it's not the one your doctors want to sign reports on at home? The most current example of this next one is ICD-10. It goes into effect in October, so basically 60 days from now. And some of the states are just now releasing their revised state report specifications as far as what they want from ICD-10, or making the changes to accommodate ICD-10. That is a very short amount of time for most vendors to make the coding changes, test it, and then push out those updates to customers. This last one I want to focus on for a minute. The Office of Civil Rights is the governing body that defines HIPAA audit protocols. And they stipulate to be HIPAA compliant, you have to be able to address 3 areas: privacy, security, and breach notification. The privacy one is the one you're probably most familiar with, providing notices of privacy practices and PHI. You probably posted your privacy notices in your lobbies years ago. It also includes right to request privacy protection, and also being able to provide information about who accessed the patient's health record. The other 2 are equally important. Security is the administrative, physical, and technical safeguards. What are your safeguards to secure your data center and protect against hacks and breaches? In your center, you may house your system servers. If the room isn't locked and secure, one of your staff can come and take that server with all of the patient's information. It's unlikely to happen, but it could. For HIPAA compliance, you have to have safeguards around that to prevent that from happening. The last one is breach notification. So should anything ever happen, you have to be able to notify every patient that was impacted. So these challenges, all 3 of these categories, are very real challenges, but they're not insurmountable, and there are ways to overcome them. So we went through all the why not and the common barriers that you hear and are around EHRs. Then let's switch gear and talk about why you should do it. I love this image of the fax machine because it represents the way we always have done it, so to speak, in healthcare. And change can be difficult without a compelling reason. So healthcare providers are now leveraging all available technology, from the internet to video conferencing, text messaging. They're taking pictures on their smartphones, and they're using tablets as their primary computing device. The iPhone didn't even exist until 5 years ago. And look at these adoption rates. The rapid adoption is happening because it makes providers more efficient, and they report that it's improving their patient interactions. And this next one, despite the bad reputation of EHRs, hospitals have seen significant positive results. Patient satisfaction has increased, staff retention has increased, and claims denials have decreased. When the Affordable Care Act came out, it published that their driving reasons behind healthcare reform were to increase quality, availability, and affordability of healthcare insurance. The big financial driver was to curb growth in healthcare costs. Compliance rates are up and patient stays are down, so the initiative is working. This chart is a hospital chart as well, but there are many versions of this type of graph, and they are all showing very high adoption rates. With an 83.2 adoption rate, EHRs are here to stay. For ASCs to continue to compete against hospitals and promote quality care, we cannot be left out of the technology advancement wave. So here are some of the other EHR advantages specific for the ASC market. With EHRs, patient safety goes up when clinical information is readily available. Patient's health information can be available in one place when and where it's needed. Clinicians can be alerted to things like allergies and potential medication issues, all of which lead to better patient safety. Seamless and timely care coordination is critical. Transitioning care between healthcare providers, such as discharge or transfer to hospital or emergency room, is critical time for patients when you need to do that. Coordinating care requires timely and accurate communication. With an EHR, you can do that in seconds. Quality tracking, reimbursement truly is likely to be tied to this sooner than later. It's already happening in the hospital space. You may already be doing this today manually, but with an EHR, those metrics can be entered and gathered as part of the care process, not as a separate task. This also opens doors for future clinical benchmarking. The next one, EHR should be smart enough to track your chart completion in the background and ensure you have captured the required data for regulatory compliance, whether it's JCO or AAAHC. This significantly cuts down on the amount of staff time it takes to do chart audits just to ensure everything is complete. You might have one or two or more people in your medical records staff doing nothing but making sure you have the right signature and the right documentation there. HIPAA. How do you know who looked at a chart if it's paper? How do you prove it? An EHR tracks every user's action and entry into the system. The last one is ROI. Some true hard cost savings include eliminating the cost for record retention, basically chart storage and retrieval. Each state has guidelines for how long you're required to keep patient records. In Minnesota, for example, that's forever. Well, forever in chart storage can get very expensive. Some of the softer costs include eliminating the time spent for lost charts, missing paperwork, the staff time doing the chart audits that we talked about, and prepping charts for the next day. But the most urgent reason to do it now, the market is demanding it. It's quickly becoming an expectation from your patients, physicians, and affiliated hospitals. They get all of their records electronically from those places, so why can't they get them from an ASC? This demand will likely be the reason your facility is going to want to implement an EHR long before the government ever requires it. So now let's switch gears and talk about the components of the EHR needed to future-proof your investment. The architecture is the foundation for protecting your technology investment. For the non-technical people, the word architecture or technology can be scary or overwhelming words. But if you're buying a software, that is technology. So understanding what you're buying is very important. I'm going to try and simplify this as much as I can in an attempt to help you understand. So let's use the patchwork quilt on the left as an analogy to how software has historically been developed. The coding is all intertwined. If you need to make a change to a feature that is in the middle of that quilt, how can you know exactly which threads are impacted? Each change impacts the entire software. So that means that there tends to be much longer development cycles and testing cycles just to ensure that you have the integrity of the entire software. Tracing the data path, or if you will, the individual threads in the quilt, and auditing the code can be very difficult. That leaves your system vulnerable to hacks, data corruption, and security breaches. The other thing you might hear with this patchwork quilt is that if you fix one thing, 10 other things break. Well, if you think about how that coding fits together, you can see how easily that can happen. And then at the bottom, to access that system remotely, most organizations will use a VPN connection or Citrix. So if you are outside of the facility and need to access it, that's typically the mechanism, the only mechanism to be able to access the software. So when you're stuck in a patchwork quilt architecture, your options to maintain that software or improve your performance is very limited. There's also extra cost to the organization. You have bigger servers, you added licenses for Citrix and remote desktop, and the architecture typically requires more bandwidth to get that information across. So now if we move over to the right, the three-tier architecture, it's a more modern and more disciplined approach to development. Each layer has a clear purpose, and its design is very flexible. The architecture creates a secure environment with data integrity, so i.e. there's no data corruption or lost data, and it's able to quickly adapt to new technology requirements. So let's break it down a little bit. And that top layer is the user experience. It's what the user sees on a tablet or the PC. It's the screens you enter information into. The application layer is the true engine and the brains of all the logic to do the data processing. The bottom tier is the database itself. It's completely separate. So when a new technology is plugged into the middle layer, the database is not touched, and the risk of compromising the data it's stored. There's no risk of compromising the data that's stored. Its reliability is extremely high. Redundancy can be built into each of the three tiers, eliminating the risk of data corruption, server processing overload, or any of these other issues. So with this method, the software can be accessed also via the internet in a secure way. You don't need Citrix or terminal services to access it. Regardless of whether you're at the facility locally or you're trying to access the system across the world, all you need is a browser to do it, a web browser to do it. The overall IT footprint of this three-tier architecture is much smaller than the patchwork quilt model with no additional licensing. It's more cost-effective and much more capable of adapting to whatever new and better technologies that might come out, because you just plug it into the application layer. So if you're selecting the right technology platform, you can save yourself a lot of time and money and not have to continue to chase software upgrades and software replacements. So these are some high-level categories as far as functionality goes that are only going to continue to get more complex as time goes on. How quickly a vendor can make the changes can possibly make or break your center. So let's take a look at each of these areas. We'll start with interoperability. So HL7 has several types of messages that transfer different information, demographics, orders, coding, financial information. Find out all the messages that the vendor supports. API stands for Application Programming Interface. It's the next big thing, and there's a lot of buzz around this for meaningful use stage 3. In layman's terms, an API can assist completely separate applications with sharing data. This integration gives you the best of both applications in a convenient, cost-effective way, and there's no HL7 interfaces required. The next one, data management, is such a big topic. We could probably spend an hour just on that, so I'm just going to focus on a few areas. Discrete data equals consistency. The more consistent data is in the system, the more useful that information is in the future, which leads to the next item, big data. Big data is the accumulation and the capturing of that data. The data is typically stored in a warehouse or more or less a very big server and can be used for analytics, benchmarking, clinical decision support, and many other clinical and business reasons you would want to use this data. If you're a decision maker, whether you're making clinical decisions about a patient or you're a business leader, the more information you have available, typically the better decision you're able to make. So you want the data, you just don't want it to take hours to get it. So long-term storage is going to grow over time because of the record retention rules. Data you haven't accessed in 3 years but are required to keep should be stored in a cheaper way than the patient's charts that you need readily available to you, or that, maybe in pain management, those patients come in quite regularly, so you don't want that stored in long-term storage. But be sure you're able to have those two different levels of storage. Mobile computing speaks for itself, but keep in mind, if the software is not designed to be tablet-friendly, the workflow could be awkward for the user. And if you think about it, when you've pulled up a website that wasn't mobile-friendly, it's much easier to navigate when the system is designed for the tablet. The ability for the system to work on any device lets the user be more comfortable on his or her preferred device, and you as an administrator, a lot less headaches. So moving over to workflow and usability, this is the heart of the user experience. The EHR should work the way you work. Cases are not performed one person at a time charting. Things are happening simultaneously. The EHR has to accommodate that. Your chart packs are likely procedure specific, and your preference cards are specific down to the physician level. You should have the ability to tailor your EHR workflow to that same level of specificity. Now let's say you're doing a cataract surgery in a small center. You have one piece of equipment with that equipment serial number, and the positioning of the patient may be the same every single time. So templates let you chart non-patient specific data very rapidly. So we've already touched on regulatory compliance, but I would recommend verifying what tools are available to promote and help your center meet compliance requirements. These categories cover today's needs. These are things that we know, that are known. Let's project out to the future of what's unknown or what's coming. So what's coming tomorrow is really only a prediction. But the question is, could these things become the new normal? Things like the exploding market of wearable devices. How many of you on the phone today are wearing a Fitbit or a Jawbone or an Apple Watch or any other wearable device to monitor your sleep, your heart rate, your oxygen levels, your BMI, your steps? I am. Healthcare segments like the sleep labs are already integrating to these devices. How could we benefit from this type of information in surgery centers? The next one, patient ownership of all their records and insurance information. Well, this is already happening in other countries. Patients are able to decide and transfer all or part of their records from one doctor to another. How convenient would that be? And the next one may surprise you. Deductibles are soaring. Patients with employer-paid insurance now have an average deductible of over $1,000. Patients with policies bought off the Obamacare insurance exchange have an average deductible of $5,000 with the lowest bronze tier and $2,500 with the next level up, the silver tier. The significant increase in high deductible policies over the past 8 years has a financial impact on both the patients and the facilities. Facilities are used to being able to predict cash flow because it mostly came from insurance companies. This shift to more patient financial responsibility changes that. With more procedures moving to ASCs, what tools are needed to proactively handle this trend? Meaningful use, I just want to mention it. It's likely 2 to 3 years out for ASCs, but it will be coming. ASC has already put together a committee, and HST is on it, as well as other key industry stakeholders. And the next value-based reimbursement is likely going to come out right around that same time as meaningful use. ASCs and ASC space makes perfect sense. They offer cost containment, billing simplification for patients, and they allow ASCs to gain market share. And this last one, 23-hour extended stays and convalescent stays, is the last one I want to talk about. In 2012, there were 16 ASCs in the U.S. with 23-hour stays. By 2014, that number had nearly doubled to 31 ASCs. And then this month, CMS just released 11 new codes approved for ASCs to do some more complex spine and vaginal hysterectomies. These types of surgeries have the potential for much longer recovery times, maybe even longer than 23 hours. This is where convalescent stay comes in. There are a few states already that allow this. Colorado is one of them. Colorado requires separate licensing and has very strict guidelines, but they're able to perform these complex procedures for spine, reconstructive shoulders and knees, total joints, and they're also able to do hysterectomy. There's a lot of opportunity for ASCs to expand in this area. ASCs are known for procedures being done at a lower cost with a much lower infection rate. So if you were a patient and you had a higher deductible, where would you want to have your surgery done? So some of these changes are cool. Some of them are just, small, and some of them have major impacts to your centers. Will the EHR you select be able to adapt to these things? That's what I want to talk about next. So moving on to the last topic, let's talk about some of the tools you can use as part of your evaluation. The first list is truly meant to be just a checklist. Things like the overall look and feel, the clinical charting workflow, the licensing model or device integration, etc. These can be items used for your evaluation process. So each vendor does these things a little bit differently, and this can help you compare apples to apples and document the differences and similarities. So kind of a high-level evaluation check sheet. This next list is what I'll call the tough questions. The questions that can help you evaluate the EHR's life expectancy and the overall total cost of ownership. So scalability and performance. Is the software scalable for your future growth or your joint ventures or new facilities or the new specialties you might take on? So growth and scalability could be going from 5 centers to 20, or it could mean that your same 5,000 procedures that you've done every year for the last 10 years doesn't change. But if you're storing all of that information, 5,000 procedures over 5 years, that's 25,000 cases. The EHR has significantly more storage requirements than the practice management system. You're storing HMPs, pictures, EKG results, path results, lab results, et cetera, et cetera. The database is going to grow much more quickly. So monitoring performance and adjusting for size is important so that it doesn't slow down the performance of the software. Every vendor will have this issue if given enough time and case volume. So when that does happen, how does that vendor mitigate performance and stability concerns? Which leads to the next one. What is the life expectancy of the hardware? How often does that server need to be upgraded? So given these growth rates, is it every 3 years, every 5 years? What happens if you run out of storage? What are your state record retention policies? Are you going to, and then the next question is, as part of your own operational interest, are you going to scan older charts and make them part of the EHR? Storage is going to add up quickly. So understanding what the life expectancy of the hardware that you're buying is very important. Licensing covers both the vendor software and any additional required licenses. So depending on the platform, you may have an additional overhead such as per user Microsoft licenses, VPN or Citrix costs that should be included as part of your evaluation when you're looking at total cost of ownership. The process and timeliness of upgrades goes to the heart of many things that we've talked about today. About how nimble can your facility and the EHR be? You want your vendor to continue to enhance the product and give you upgrades. So what does that process look like? How often does it happen? And is there any downtime? All good questions. What are the top 3 reasons a person calls in for support? We all have support lines. They're there to help you. So understanding the nature of the calls can help you be prepared as you do your conversion to know what to expect. It's likely if other people are having a question, you will too when it comes time to go live. How quickly can the software be adapted to meet new quality and state reporting requirements? We already talked about the ICD-10. Vendor responsiveness to these changes can give you the peace of mind to focus on other areas of your business that are impacted with these whatever new requirements that come out. How easy is it to get information into and out of the system, whether it's importing documents, scanning in old charts, or exporting patient records by patient, by day, by month, etc. What medical devices does the vendor integrate to? How does it handle non-HL7 compliant devices? Now this is one that could be a surprise cost to you as part of the implementation if it's not discussed up front. So I'd highly recommend you start now cataloging what equipment you have in your centers and if it's HL7 compliant or not. What are the options for things like scanned documents, storage of images from C-arms and scopes? There are a number of ways this can be handled. Find out what the options are for each vendor. And the last one, how does the vendor help to protect you from risks of HIPAA violations and security breaches? This can be anything from audit log capabilities of the system to the more IT-related questions about database security. So I'm going to conclude with some parting thoughts. Ambulatory surgery centers are going to continue to become an increasingly critical component of the care continuum. We are a part of the solution for reducing healthcare costs in this country. By taking a leadership position in the adoption of an EHR, we as an industry can demonstrate more to patients and partnering hospitals, thereby promoting even more procedures being authorized in the ASC setting. We have a proven track record of providing better care at a lower cost with lower infection rates. Without the ability to exchange data electronically, reliably, and quickly, the ceiling will remain low for what's truly possible and what is best for patient care. So each of you are very much a part of creating the future and telling us, the vendors, what you need to succeed and to continue to make ASCs the safest place for surgery. We as vendors in return owe it to you and to your patients to provide you with a reliable, scalable, and adaptable EHR that will protect your investment and carry you into the future for any of the unknowns that are yet to come. So I thank you for your time sitting in on today's webinar. Carrie, I'm going to pass the controls back to you if you want to open up the lines for any questions the audience may have.
Great. Thank you, Tara, for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A and follow up on questions they do not have the opportunity to address. And it looks like we have a few questions coming in here. The first one is, if I pulled the trigger today and bought an EHR, how long does it take to implement and go live?
Okay, that's a good question. And it can really vary based on the complexity of the implementation. Some of the complexity things, how many centers, number of specialties, number of integrations, etc. But I will say that there's a few things that you can be doing right now to cut down on that implementation time frame. You can start today by reviewing your workflows. Maybe your chart that was set up 10 years ago doesn't follow the true sequence of what's being charted. So if you watch your staff and you see them looking at a paper and they flip it back and they check something and they flip it back again, that sequence might not be in line with how you're doing things today. So this is really the time to optimize that workflow. Other things you can do is get the staff participation. So get a committee together with stakeholders of all different kinds, from the nurse to the doctors, administrators, and the tech-savvy folks, and determine what your must-haves are, what your like-to-haves are, and what your wish list is prior to doing vendor evaluations. The review of your existing workflows, that'll help you create those lists. And as I mentioned earlier, I would start to make a list of what equipment you have and what HL7 capabilities there are, and do the same with the software vendors that you work with. So these are all things you can do ahead of time. But once you've selected a vendor, the setup and training can probably be done in as little as 60 days. But all the above things are what tend to slow down the implementation. So one last tip on this subject, take the time and create incentives for your staff to train. A well-trained staff and an excited staff will make for a much more successful implementation.
Great, thank you. We have another question coming in here. Is it safe to put an EHR in the cloud?
Well, with the right technology, I would say that it is a much better way to deploy an EHR. It's a good question because it's really the ultimate way of future-proofing your investment, what we've been talking about today. The performance is better, it's much more efficient, you have built-in disaster recovery. It's hurricane season right now in Florida, and it's earthquake season all the time in California, so having a server on site might not be that safe. Also, your HIPAA security is elevated. So people think that it's more secure to have a box on site in a closet, but it's really quite the opposite. A certified cloud data center has 24/7 security around those servers with a lot of safeguards against hacking. So that's why you're able to do banking in the cloud, and they're able to secure that. It's ultimately cheaper for many reasons than the traditional deployment model as well. So I would say yes, definitely it's safer.
Great. Another question coming in here. With an EHR, will I have to replace all of my equipment?
Well, with a LAN deployment, or in other words, you're buying the server on site, then I would say yes, you most likely will. With a cloud deployment, no. But when we talk about equipment, let me go back to monitors for just a second. If you look at your monitors, you may want to consider upgrading those. It's probably costly, and since ASCs try to keep their costs as low, you might be able to buy a refurbished patient monitor for cheaper, but if it doesn't have HL7 capabilities, you might want to spend a little more for a new one.
Great. We have a couple of other questions coming in from the audience. And here, one of our listeners wants to know if you're seeing any ASCs doing device integration for interoperability and PACU.
So the device integration really goes back to these patient monitors that I was talking about. So really, regardless of what the monitor is, it's really going to depend on its HL7 capabilities. And beyond that, there are ways to integrate non-HL7 compliant devices, but it can be costly to do that. So that's really going to depend on a device-by-device device-by-device type of an assessment.
Great, thank you. We have another listener asking you to discuss the anesthesia functionality that will be available in the first quarter of 2016 release.
Well, I'll discuss anesthesia functionality in general, that yes, we will be offering anesthesia functionality as part of that. And the anesthesia tends to be an area that some centers want, some anesthesiologists want, some don't. So during your evaluation, they should be a part of the assessment team if they're going to be using it. So trying to make something very user-friendly is definitely important to us.
Great. Thank you. And just as a reminder to our listeners, if you have any additional questions, you can feel free to enter them in the panel on your screen. Looks like we have a few more coming in. One of our listeners would like to know, can I use my own forms in the EHRs in the marketplace? If so, what is the process and cost to convert them?
Your EHR should be based on your forms. So the answer would be yes. Building up your, setting up your workflow. So I talked about the first question as far as the how to go live and evaluate your workflow. So that includes your forms. So what are the forms, what are your consent forms, and building all of those in. Because the idea of an EHR is to eliminate paper. There are some systems out there, or actually probably most, that can allow you to eliminate paper completely, but it needs to be enforced. But the capabilities of building in your consent forms and being able to capture electronic signatures and all of that, the capability is there, but it would need to be enforced. This tends to be more of a leadership thing. But creating those forms, optimizing your workflows, and the capability of eliminating paper completely, yes, that's definitely there.
Great. Thank you. That looks like those are the only questions we have coming in. I want to again thank our presenters for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.